Hello and welcome to this lesson, Insulinoma. So first let's understand what is insulinoma. Insulinoma is a rare tumor of pancreas, and this is a tumor that is usually benign and it is coming from neuroendocrine cells of the pancreas. So it is coming from the beta cells of the pancreas. So as you know, the beta cells are responsible for production of insulin. So in this case, in case of insulinoma, we have overproliferation of the beta cells, and as the result, we have overproduction of the insulin. And overproduction of insulin leads to severe hypoglycemia, and because of the fact that high insulin level is responsible for hypoglycemia, we are going to call this hyperinsulinemic hypoglycemia. This is a tumor that is usually sporadic and solitary, but it can be also associated with MEN1 syndrome. MEN is standing for multiple endocrine neoplasia type 1, and insulinoma can be associated with this tumor. The peak of onset for this disease is somewhere between 40 and 60 years of age. So here in this picture, you can see islet of Langerhans inside the pancreas. So as you can see, we have many types of neuroendocrine cells. We have beta cells, which are responsible for insulinoma, which are responsible for secretion of insulin. We have alpha cells, they are secreting glucagon, increasing the blood glucose. We have F cells that are responsible for production of pancreatic polypeptides. We also have delta cells, which are responsible for production of somatostatin. Now, what is the pathophysiology involved in case of insulinoma? First of all, insulin secretion is going to be unregulated in case of insulinoma because cancer cells do not listen to the feedbacks. So as the result, we have excess and unregulated insulin secretion, and the patient is going to have lowering of the blood glucose. Another point behind the pathophysiology of the insulinoma is the fact that as the result of excess insulin, we have increased uptake of the glucose by the tissues around the body, and this uptake of the glucose causes inhibition of gluconeogenesis and glycogenolysis inside the liver. So these two pathways, gluconeogenesis and glycogenolysis, are glucose enhancing metabolisms and pathways inside the body. So when we have inhibition of gluconeogenesis and glycogenolysis, the excess amount of insulin that is causing hypoglycemia is not going to be encountered by counter-regulatory mechanisms. Another point is that excess amount of insulin causes reduction in other glucose enhancing hormones. For example, the secretion of the glucagon is going to be inhibited. So as the result, the patient is going to have persistent hypoglycemia as the main symptom of this disease. Another point, the third part of the pathophysiology, is that the abnormal cells of the insulinoma are not going to listen to the normal feedback mechanisms in the body because these are cancer cells, and as the result, the regulation of the insulin secretion is not going to exist inside the body. So what are the signs and symptoms of insulinoma? Here basically we have signs and symptoms of hypoglycemia. We define a triad which is called Whipple triad. So first of all, the patient is going to have signs and symptoms of hypoglycemia, and we can subdivide this into two sections. First of all, we have neuroglycopenic symptoms like dizziness, confusion, and blurred vision. Also, the patient might have autonomic symptoms like sweating, palpitation, and tremor. Another point is that during an attack episode, the patient is going to have blood glucose of less than 50 milligram per deciliter. Another point is that because of the fact that all the symptoms are caused by low blood glucose, the administration of the glucose causes a relief of the symptoms, and this may cause a problem for the patient because sometimes patients, in order to avoid episodes of hypoglycemia, they try to have frequent eating, and as the result, they are going to have weight gain as the result of their actions. Now, what are the diagnostic tools that we can use for insulinoma? The best test that we have is fasting test, and this is a 72-hour supervised fast, and it is gold standard for diagnosis of insulinoma. So during the fast, the blood samples are taken from the patient periodically, and we are going to measure 4 components in the blood. We are going to measure glucose, insulin, C-peptide, and proinsulin. So the aim for measuring these components is to determine if the insulin is endogenous or exogenous. So in case of having exogenous insulin, we are going to have high amount of insulin and low amount of C-peptide and proinsulin. But in case of insulinoma, which is an endogenous source of insulin, we are going to have high amount of insulin, high amount of C-peptide, and high amount of proinsulin. So the test is positive when blood glucose is less than 45 milligram per deciliter. We have positive test when the insulin is 6 microgram per milliliter, and this confirms the endogenous insulin production. Also, the proinsulin is going to be more than 20% of total insulin, and C-peptide more than 0.2 nanomole per liter. So we have other tests, we have other imaging tests for localization of the tumor. So the first test that we are going to do in case of insulinoma is CT or MRI, and this is usually a first line imaging. And in case of CT or MRI, what you are going to see is a hypervascular lesion in the pancreas. We can do another test, endoscopic ultrasound, and this is a very sensitive test for small lesions in the pancreas, and usually you are going to see these small lesions in the head and body of the pancreas. There is another test which is called selective arterial calcium stimulation. This is an invasive technique where the calcium gluconate is going to be injected into the pancreatic artery, and after that we are going to measure the insulin in order to localize the tumor. So probably the most important part for your exam is differentiating insulinoma from other conditions that can cause hypoglycemia. The first one, probably the most important part, is the factitious hypoglycemia, when the exogenous insulin is responsible for hypoglycemia. But remember, when we have exogenous insulin administration, we are going to have high insulin level, low C-peptide, and low proinsulin level inside the body. But in case of insulinoma, which is an endogenous source for insulin, we are going to have high insulin, high C-peptide, and high proinsulin. Another differential that you have to know for your board examination is reactive hypoglycemia, and this is usually common in person who is pre-diabetics or the patient who have had gastric surgery. Another differential is sulfonylurea or meglitenide. These are oral hypoglycemic drugs that stimulate insulin secretion and release, and they can cause hypoglycemia. This is more of a problem in person who is older in age or the person who has renal failure. Remember that excretion of the insulin is via renal excretion. So with age or with renal failure, we have decline in renal excretion. So as the result, insulin is going to stay in the body more and can cause hypoglycemia. Another differential that you have to know for your board examination is adrenal insufficiency. So in case of adrenal insufficiency, we have low amount of cortisol. Cortisol is a stimulant for gluconeogenesis pathway. So gluconeogenesis is not going to be run in the body properly. So as the result, the patient is going to have hypoglycemia. But adrenal insufficiency can be associated with other symptoms like hyperpigmentation, fatigue, and weight loss. So another differential for hypoglycemia and insulinoma is hypopituitarism. So in case of hypopituitarism, we have low amount of pituitary hormones, and two of most important hormones for regulation of insulins that are stimulated by pituitary gland is cortisol and growth hormone. So when we have hypopituitarism, we have low pituitary hormones, and as the result, the regulation of the glucose is going to have some problem as the result. So here in this picture, you can see the regulation of the cortisol and growth hormone. In the left side, you can see hypothalamus, which is releasing the corticotropin releasing hormone. It is going to affect the anterior pituitary gland, and anterior pituitary gland is going to release the ACTH, adrenocorticotropic hormone, and adrenocorticotropic hormone is going to stimulate adrenal cortex, and as the result, we have secretion of the cortisol. In the right side, you can see the regulation of the growth hormone. So in the hypothalamus, we have release of growth hormone releasing hormone, which is going to stimulate the pituitary gland, and as the result, growth hormone is going to be released, and growth hormone can actually regulate the amount of glucose via affecting the liver and also free fatty acids in adipocytes. So another differential for insulinoma and hypoglycemia is severe liver diseases. Recall that the liver is responsible for gluconeogenesis and glycogenolysis. These are two pathways that are responsible for elevation of the blood glucose in the body. So if the patient is not having proper function in liver, for example cirrhosis or even fulminant hepatic failure, the patient is not going to have proper amount of gluconeogenesis and glycogenolysis, and as the result the hypoglycemia is going to be developed. Another differential is renal failure. So again, recall that the excretion of the insulin is via renal excretion. So when the patient is having, for example, chronic kidney disease, the patient is not going to have proper clearance of insulin inside the body, and as the result the patient is going to present with prolonged hypoglycemia episodes. But this is going to be added to signs and symptoms of renal failure like uremia. So what are the managements for insulinoma? Since most of the cases of insulinoma are benign cases, usually the primary treatment for insulinoma is going to be surgical treatment and surgical resection of the tumor, and this can be curative for most of the patients. But if the patient is not a candidate for the surgery, or we want to use medical management as a bridge to the surgery, we can use medical management. And the first point in medical management is the dietary modification. The patient is advised to have a small and frequent meals with complex carbohydrates, and this causes the maintaining of the blood glucose in the longer term. Another point that we have in the medical management is a drug diazoxide. This is inhibiting the release of the insulin, and it is reserved for the patients who cannot undergo the surgery or they are awaiting the surgery. Another drug that we can use is octreotide. This is a somatostatin analog. Again, recall from the physiology that somatostatin hormone is inhibiting the release of the insulin, and this drug, which is analog of somatostatin, can be used for management of insulinoma. So this is a classical case scenario that you can see in the board examination. Here we have a 45-year-old woman who is presenting with episodes of confusion, sweating, palpitation, and blurry vision. These are neuroglycopenic and autonomic symptoms caused by hypoglycemia, and as you can see here, we have precipitation of the symptoms after early morning or after missing a meal. Early morning and missing a meal are causing hypoglycemia in the patient and causing increase in severity of the symptoms. So the symptoms are going to be resolved with orange juice or candy. These are sources of sugar and causing elevation in the blood sugar, and physical exam is unremarkable. So in the 72-hour fast, we have drop in blood glucose to 38 milligram per deciliter with elevated insulin, C-peptide, and proinsulin. So this is confirming the endogenous source of the insulin. And CT of the abdomen shows a 1.2 centimeter hypervascular lesion in the tail of the pancreas. So the patient is going to have laparoscopic resection of the tail of the pancreas, and as the result, the symptoms are going to be resolved after that in the follow-up. Thank you for watching.